Hey guys, it's Charles and welcome to Good Clinical, a podcast and YouTube channel dedicated to showcasing the future of medicine and human health. Today's guest is Associate Professor Rodger Tiedemann. Rodger is a clinician, a haematologist, a researcher, and an advocate for more medicines access and clinical research in New Zealand. Welcome to the podcast, Rodger, and great to have you, and thank you for making the time in what I imagine is a very busy schedule.
Thank you, Charles. It's great to be here. Thank you.
So why don't we set the scene? So with all those different roles, all those different attributes that you have, how did you, what was the journey that you went on accumulating all these different interests and all these different capabilities and vocations, I guess?
Right. Yeah. Well, out of school, I was really interested in helping people and interested in science. I went into medicine, and along the way, I discovered that cancer treatment was interesting and developing, and I wanted to go into that area. And haematology was really leading the way in terms of cancer treatment, so I went into haematology. Mm-hmm. And then I was very interested in the research side of things, rather than just sort of applying things out of books. I wanted to, be there at the forefront, and so I did a PhD, and then ended up doing a postdoctoral studies at Mayo Clinic in the US, and then the Mayo Clinic gave me a job as a consultant there. And then after a while, I moved to Princess Margaret Hospital in Canada, in Toronto, where I set up a research lab, and I ran that, and I'm still running that lab in Toronto now. I was there for 12 years and then ultimately came back to New Zealand in 2022, mainly for family reasons with parents getting older. Mm-hmm. Yep.
Now, I'm just going to jump right into it, but will there ever be a cure for blood cancers or cancers in general, do you think?
Well, a number of blood cancers are already curable. Yeah. I think Hodgkin's lymphoma and some patients with AML, acute myeloid leukemia or acute lymphocytic leukemia. So there are curable blood cancers out there, but there are also incurable blood cancers, and often those are the ones that grow slower but then respond less well to treatment. So we need to keep retreating people.
Because that's a question I often get asked as someone that works in this space and adjacent, nowhere near on the forefront like yourself, but they're always like, there's got to be a cure out there for everything, but they're just holding it back. And, it's part of this idea that cancer is just one thing, or diseases are just, a type of disease is just one thing that's happening that's going wrong. But cancer, there's so much variety and there's so much heterogeneity even within a type, right? So It's like figuring out what is going to move the needle, and when it comes to like a functional treatment or a functional cure, that's a really hard thing to work out, which is why we don't have cures for everything.
That's correct. So even within one patient's cancer, there's a spectrum of different cells that are involved. They often vary a little bit one from another. There's different genetics within those different cells. And then patients have different immune systems and other supporting cells around their tumor. So there's an awful lot of heterogeneity to deal with. But I am an optimist. I think most cancers will eventually be cured. I think, understanding what is going on and being able to profile that well in patients will allow us to, take the next step and start curing these some of these incurable cancers. And we're already seeing that some of the immunotherapies that are coming out, where we, engage the patient's immune system to attack the cancer, work incredibly well, and some of those treatments are curative in some previously incurable cancers, metastatic melanoma and renal cell cancer. Those things have, we're starting to see cures in some of those patients with PD-1 inhibitors, and similarly with relapsed Hodgkin's lymphoma. We can cure patients now with some of those treatments. So there is a lot of hope, I think, with those treatments. And in the cancer that I treat, which is multiple myeloma, there's been an incredible progress with CAR T cells and bispecific antibodies and just even monoclonal antibodies in treating that, and patients are living many years longer as a result of those treatments.
What's a bispecific antibody?
A bispecific antibody is a engineered antibody that has two arms, and one arm binds to the cancer cell, some unique epitope on the cancer cell, and the other arm binds to typically a T lymphocyte or an immune cell, and brings the two together. And then all of a sudden the T cell recognizes there's a cancer cell there and attacks it, and that can be a highly effective way to engage the immune system to attack a patient's cancer.
Because you've got all these different new treatments. So CAR T that uses the immune system. You've got like a genetically modified, essentially, version of the patient's cells.
Correct.
T cells in
Yep.
this case. And there's other versions of other CARs you can do.
Yep.
Chimeric antigen receptors. So it doesn't have to be T cells, right? You can have like your natural killers. I think there are different versions. Probably there's going to be heaps.
Yeah, there's other
down the
versions
line.
out there. Yep.
And it really speaks to the importance of a good immune system, right? Like when you have the cancer, but also the importance of the immune system before you develop a cancer, because the immune system is constantly surveilling for outside pathogens, but also aberrations that happen to your own cells.
Totally correct. You know, to get a cancer, those cancer cells must have learnt to evade the immune system. So they all have some trick that allows them to evade the immune system. And if you know what trick that they're using to evade the immune system, you can block that, and then all of a sudden the immune system recognizes them again.
Are there like a handful of tricks that these cancer cells have, or is it quite a wide variety?
There's a huge variety of them, but a number of them do inactivate the T cells as the T cells come close, which is why we can reactivate those T cells with the PD-1 inhibitor class of antibodies. And then there are other ones that sort of down-regulate or suppress the expression of antigens on their surface so that the immune system can no longer see them.
Oh, right. It's almost like invisible to the surveillance.
Stealth mode. Sort of thing.
Stealth mode. Gosh, these crafty little things, aren't they?
Yeah.
You know, but this all these mutations that happen, that they get these additional capabilities, traits, or whatever. It's all random chance, right? It's mutations happening obviously at the DNA level, which filter their way down.
Right, yeah, for sure. Those
Like
mutations do happen randomly, and then there's millions of cells there. The ones that have the profitable mutations are the ones that sort of gradually take over.
Yeah, it's just a natural process of natural selection, essentially. Right. So this evolutionary arms race, immune system versus cancer cell population, trying to figure out how to evade.
Yep.
Well, that was. I mean, it's fascinating how we kind of talk about these cancer cells as almost like that means it's part of us and it is our DNA if you're a cancer patient, and yet we kind of talk about it as though it's something that's completely foreign. You know what I mean? And then
that is the pathos of cancer, is that it's part of us. It's part of us that's gone wrong, and that also is part of what makes it so difficult to treat, is that we have to be able to target those cells which are very similar to self without damaging all the other cells that are self.
Yeah. And I suppose if you go back to the most brute force, blunt tool of cancer therapy, it's chemotherapy, which is basically kill everything, but at varying rates, and ideally the cancer before you kill the patient.
Right. So most chemos work by killing the fastest growing cells, which is typically the cancer cells, and then they have a little bit of tissue specificity as well. It kind of helps them focus in on the cancer. Right. But you're right, it's pretty much a blunt tool.
Yeah. And over time, we've obviously got more specific. I mean, are CAR T cells like the most targeted, personalized end of the scale?
Yeah, I think the immune therapies are not really chemotherapy. They're not targeting proliferating cells. They're very targeted, very specific to one cell type that might express an antigen that's been targeted by the immune therapy, a protein on the surface of the cell that's been that's being targeted by the immune therapy. So they are very specific. I don't know. They're not always. It's not always necessarily required to personalise those treatments. So some of those treatments can work for a broad swathe of cancers of a certain type, and you can just if they work for 80% of that particular cancer type, you can apply them without really doing any serious molecular testing, although ideally it would be nice to know the 20% that don't respond and put them straight on something else.
Yeah, 100%. So tell me, your area of expertise is the multiple myeloma. What got you interested in that, and what's the latest happening in this field?
Yeah, well, I got interested in myeloma back in the early 2000s. And it was mainly because the outcomes were so poor back then, and it really needed a research effort to push the frontiers, push the boundaries, improve patient outcomes. People back then were living 3 years with a stem cell transplant. That was with high-dose chemotherapy that wiped out all their bone marrow stem cells, and still they only lived 3 years. And the patients that weren't up to that kind of intensity of treatment did worse.
And myeloma is a cancer of what type of cell?
myeloma is a cancer of a type of cell called plasma cells. So these are actually part of the immune system, and they have gone wrong. They've acquired mutations that allow them to proliferate unchecked, and so they form a big clone of cells, aggregates, nodules inside the bone marrow, and gradually they eat away and cause holes to develop in the bones, and they also secrete a protein that damages the kidneys, and they cause marrow failure.
Yikes.
So
great.
in recent years, there's been huge progress in the treatment of myeloma. So there's drugs called proteasome inhibitors, there's drugs called immunomodulatory drugs, or IMiDs. They all came out in the 2010s. And in the last, and then in sort of 2014, there was a new monoclonal antibody called daratumumab, followed by another monoclonal antibody, isatuximab, which really dramatically improved the outcome of myeloma patients when used in combination with these other drugs. And then more recently, there's been a number of different bispecific antibodies that have come out for myeloma and CAR T cells. And these bispecific antibodies target 3 different antigens. So there's a whole number of different lines of treatments that patients can now go on to if they live overseas.
We'll get to that point because
Right.
that's a really important one,
Yeah.
for sure. I mean, it speaks to the complexity of just finding a treatment for these various different cancers. So myeloma, so you got the plasma cells that have got a mutation, so they're now undetectable by the rest of the immune system, but they're originally part of the immune system. So it's like the immune system failing to detect errors in its own immune system
Correct.
cells.
Yep.
Yeah, which propagate over time, and then you end up with a cancer. Okay. So, I mean, it's a tricky... So you're of the mind that eventually we'll get to a point where basically all the cancers will be resolved enough that we'll find a cure for these
Right.
things.
So I have a research lab in Toronto where we study multiple myeloma, and I think it's just a good case example for many different cancers. For the last 50 years, we've been trying to treat myeloma by targeting these plasma cells, but in our work, we've discovered that there are more primitive pre-plasma cells, or B cells, that also have all of those genetic mutations that the plasma cells do. They're very rare cells, but when we track those cells in patients using DNA fingerprinting, we're able to show that those cells in many patients are the cells that cause relapse. After they've been treated, those patients have been treated with anti-plasma cell treatment. And so we do believe that one day there'll be a cure for multiple myeloma by targeting those cells as well as the plasma cells, any spectrum of cells in between. But I think once we've done that, and the therapies are out there that potentially could do that, that we could be heading towards a cure for myeloma at some point. Yeah. So, and I think the same thing applies for many other cancers. Once we have better understanding of where the cells come from, what are the resistant cells, how do the cells escape the immune system, we can apply the right tools, and eventually we'll get there and be able to cure these things.
Why don't we see the myeloma happening in the B cells? The myeloma comes from the plasma cells, which come from B cells.
Yep.
But only once they have, developed into plasma cells?
It's a brilliant question. Yeah. And to just try and explain that, the mutations that we see in myeloma involve oncogenes. Those are genes that drive the cell to become a cancer cell, being translocated or moved close to a genetic enhancer in the plasma cell. And those enhancers are only expressed in plasma cells, but they're not expressed in B cells. So even though the mutation arises in the B cell, the B cell doesn't become a cancer because those enhancers aren't active in those cells. But when that cell matures into a plasma cell, that enhancer switches on, and all of a sudden the cancer gene switches on, and now, bingo, you've got a cancer of plasma cells. And you treat the plasma cells with the treatment, and those cells go away, but you're left with these earlier populations of cells that don't even look like cancer cells because they're not switching on that oncogene or that cancer-causing gene. But they're there, and as soon as they mature, they cause a relapse.
Wow, that's so crazy.
Yeah.
So, I mean, if you go all the way back to the beginning, you have to have that oncogene, which is a mutated version of a gene that drives growth in the right circumstances.
Exactly.
But that has to be has to be relocated, translocated from its normal position to another position, so that when something else happens, it turns that oncogene on.
It gets overexpressed, and
Yeah.
all of a sudden the cell starts doing crazy things like growing unchecked.
Right. So in a normal circumstance, there would be some level of expression of that oncogene, but because it's been translocated to where it gets enhanced,
Yep.
it's overexpressed, and that drives it.
Right.
What the?
Yeah, exactly right. And so, but those earlier cells, where the mutation actually arises, they're really not susceptible to that mutation because they don't have that environment for that enhancer to be active. And so it's kind of like a silent mutation until the cells mature, and then all of a sudden you see the the growth of the cells.
Right. So in a perfect ideal world, you would want to DNA fingerprint a patient early on before they have any cancer and see if they have this genetic fingerprint of the oncogene translocated into a position next to the enhancer, so that in 5 or 10 years' time, they are at risk of myeloma.
Yes, we screen patients with much more simple tools than that. I mean, these are research tools, but we screen patients just looking for spikes of protein in the blood that we often see for up to 10 years before a patient gets myeloma.
Okay.
So that much cheaper and more simple way of looking for them.
Yeah.
But you're right. If I think in the future, if we were to look at minimal residual disease in treated myeloma patients, we should be looking for those cells as well. And attempting to address those cells as well as the plasma cells, because we believe that, and the data shows that those cells do cause relapse.
Yeah, so those cells with that particular fingerprint, let's just call it that for ease of conversation, but those are the ones that drive relapse. Do they drive the initial presentation of myeloma as well, or are there other?
I'm sure they do. They're a stepping stone to the initial presentation.
Right, because they are the progenitor of the plasma cell, which...
Correct.
Okay,
correct.
Yeah, now I'm with you.
Yeah.
Gotcha. That's fascinating. Okay.
Yeah.
Yeah. Now let's go back to the comment you made earlier, where there are treatments available, where you were working for a while in Canada, which aren't available in New Zealand. What's going on there?
So, I came back from Canada to New Zealand in 2022. As you can see, I'm quite interested in research. I'm a research guy. I'm an associate professor. This is what I do, run a lab and see patients. But when I came back here in the clinic, I realized that there was very little to treat myeloma patients with. I was astounded. So many of the medicines that are available overseas just aren't available here. And I realized I had to get into advocacy. I just couldn't sit by and let that continue on because Kiwis are missing out.
Yep.
So we're missing out on carfilzomib. That's the most active proteasome inhibitor for myeloma. We were missing out on pomalidomide that's been funded now that it's off patent. Pharmex saw it sufficient to fund that. We're missing out on the anti-CD38 monoclonal antibodies, and we can talk about how effective they are. And we're missing out on all of these new bispecific antibodies and CAR T cells, many of which are on clinical trial, but some of which are approved in North America and Europe. And we don't have access to any of those. And even getting clinical trial access to those medicines is very difficult here. And so it became apparent that I would just have to, become more of an advocate for New Zealand treating people appropriately and making use of the tools that are out there to treat myeloma and other cancers.
Yeah. So as a physician, you've got a patient with myeloma and you don't have the full menu of treatments available. So you have... So I read a stat that New Zealand is essentially 10 years behind the OECD average in terms of access. So we're not like middle of the pack. We're like bottom of the pack.
We're pretty close to the bottom of the OECD.
Yeah.
There are a couple where there's no data, and then we're the bottom.
Right. Okay. So geez. Okay.
In terms of medicines access or new medicines, funding of modern medicines.
So is it, I mean, this is maybe a very blunt thing to say, but does it feel almost like you're practicing medicine from 10, 15 years ago if you're deploying these old tools?
Yeah, I think it's close to 10 years ago. We just got pomalidomide. That came out in like 2012 or something.
Yeah.
The monoclonal antibodies, anti-CD38 antibodies, which came out 2014. They took a few years to get funded in other countries. Not everyone's up there with America, but we still don't have that now. And I think the application went in more than 7 years ago in New Zealand
Yes.
for that to be funded. So,
because there's two parts to the scenario, right? There's the market authorization or the registration of the drug to be sold, and then there's the pharmac funding of the drug.
Correct.
And those things could happen. Well, if the second one ever happens at all, they could also happen very far away from each other in terms of a timeline.
right.
So like you said, application 7 years ago, only now
Yeah.
has got funding approval from pharmac.
So if we compare New Zealand with the UK, our GDP per person, per capita, is about the same, actually, in New Zealand and the UK. The UK, when daratumumab went forward for assessment there, I think they had 2 committee meetings. There was a high level of, it was ranked very highly, and I think it was funded within 3 months or something of those meetings. In New Zealand, I think there's been 5 or 6 reviews of daratumumab. The first one was, gave it a low ranking, and gradually the ranking's gone up. It's had a number of favourable rankings, and still it isn't funded 7 years down the track. So it's really, you have to ask, why is that happening?
Yeah. So I suppose if you're a patient with myeloma, you've won the say like medicinal lottery if you live in the US because you have a full host.
Not necessarily.
And you have adequate coverage, shall we say.
Yep.
Yeah, that's the key thing for the US.
That's key in the US.
Whereas in New Zealand, most people don't have their own health plans. Most people rely on public health. And even if you have, say Southern Cross or something, you might not get full coverage, it'll be a certain portion.
Yeah.
Do you think that we need to rethink this whole approach of just relying on, the public health system to make available drugs in this?
Well, I like socialised medicine. I do like the approach of, being able to treat everyone equally, and people who are needing treatment, that they get it. I'm not a big fan of the American system, and I've worked there, and I don't like the fact that some people miss out because they don't have insurance or whatnot. But there are many socialised systems out there, and most of them are doing better than the New Zealand system in terms of medicines access.
Yeah.
UK, Australia, France, Italy, Spain, many of those countries, they all have socialised medicine or insured medicines and access for all. And the access is better in all of those countries. And all of those countries, so New Zealand has a GDP per capita that's the same as the UK, but it's better than France, Spain, Italy, Japan, and we have a lower general government debt than all of those countries. And yet, in the 5 years up to 2022, those countries funded between 150 and 100 new medicines per country. We funded 17. And we're technically in at least as good as, if not better, financial situation than those countries. I know, all the bad news out of the government and in the papers, but if you go to the OECD website or the International Bank website, you can look up these statistics for yourself. We rank 31st or something in the world for GDP. We're not as poor as people would like to make out. We do have the money to afford medicines, but we don't spend on medicines. And so Kiwis with cancer, Kiwis with other health conditions are missing out.
Yeah.
And we've accumulated this huge deficit in access to modern medicines, so that, when I come back from Canada, I just see that we're missing out on so many medicines for patients, and patients just simply die early and suffer as a result of that.
Do you think it's a budget issue or it's a valuation issue? How you value where you allocate that your budget, right? So it's like, how much do you have versus how do you spend the budget?
Yeah.
Which of those two issues do you think it is?
I think there's various tiers to the problem, but I think it starts with a valuation issue, but that was a judgment I think was made a long time ago, and then what's happened in New Zealand is that pharmac was set up with this silo of funding for medicines, and the general health expenditure doesn't really affect that silo, and that silo can't benefit from general health expenditure. And whereas New Zealand's general health expenditure, at least the way that the government counts for it, appears on par with other countries, our expenditure on medicines is well down. It's about a third of what other countries spend per GDP. And so part of the problem now is that we have this siloed and shrinking expenditure on medicines. And when I say it's shrinking relative to population growth and inflation.
Yep.
So in real terms, it has shrunk dramatically over the last 10, 15, 20 years. It's been a long-term problem, and so we've accumulated this huge deficit in medicines, and we don't allow the health expenditure to intermix with the spending on medicines. And whereas the health expenditure, apparently, according to government statistics, has kept up, the medicines expenditure hasn't.
Right. So I suppose when you have it siloed that way, you kind of alluded to it, but if you have a medicine that would have an impact on the general health spending, so like you cure someone earlier, they're less time in hospital, they're back into back at work, paying tax, all these are kind of indirect aspects. You're not recognizing any of that, so it doesn't get made as part of the evaluation of how important this drug may or may not be.
Absolutely correct. So, initially the Pharmac calculations have been based on, expenditure per health quality of life years, but they often haven't involved those other more systemic calculations. How much is the cost of caring for that patient otherwise going to cost the health system? How much is it going to cost in terms of lost profitability in their career and to their families, and the cost of suffering that's involved by families and the community. And I think there is more enthusiasm to move to a broader understanding of the true costs of not treating people.
Yes.
But it's taken a long time to get there, and it still hasn't really got there in a significant way.
Yeah. I suppose Pharmac was originally set up as a cost minimization kind of vanguard, I suppose. Like, how do we advocate for this small country, bottom of the South Pacific, big pharma companies, we're like bottom of the tier, bottom of the barrel, no one really cares about us, whatever. But how do we get medicines to this country enough to support it? But you play that out over 10 years, and the world's kind of moved on, but the model hasn't moved on. And medicines are becoming increasingly more not personalized, but specialized or specific. You referred to the bispecific antibodies, CAR T, monoclonals, all the kind of thing. They're a lot more, specific than, say, a bunch of paracetamol for pain.
Right.
But the approach hasn't evolved over time, is basically what I'm saying.
That is the problem. So I totally get why Pharmac was set up in the 1990s, and it did a great job then by sort of creating this bigger market, stronger competitive advantage in terms of negotiating for medicines by bringing all of the smaller hospital providers in under the one umbrella. And initially it achieved a lot of savings by doing that, and has also been good at moving the country to lower cost generic medicines rather than brand name medicines. We actually have one of the highest percentage of generic medicines in New Zealand internationally. Okay. So Pharmac is already doing as much as it can to save money. But the problem is that the government has treated it a bit like a cash cow or a savings cow. Yeah. They haven't put any money into it to keep up with the progression of medicine and treatments that are available for patients. They've just taken it for granted that they can continue to make savings on Pharmac, and so people are missing out. Kiwis are missing out, and you may not realize it until someone in your family gets cancer or a serious illness, but then suddenly the realization comes, hey, there are all these treatments out there, but we can't get them.
Yeah. So what happens to a patient that can't get them? I mean, either they go, okay, well, I get whatever I can get, or do some people go outside of New Zealand, start looking elsewhere?
Yeah, there are three options, right? So patients can self-fund the medicine, which some do. They can move to a country that provides that treatment if they're able to. And for a lot of Kiwis, that's Australia. You set up shop in Australia, you get an address, a GP, and then you can access treatment there.
Is that straightforward?
That's pretty easy.
Wow.
Yeah. And at the moment that's a strategy that works, but I can see that down the track that Australia's going to look at that because they're starting to fund CAR T cells for myeloma. That's an expensive treatment. Are they really going to continue to do that if lots of Kiwis start heading over there and wanting to get on their CAR T cell program? So I think this is, the government needs to be aware that they can only get away with this strategy of letting Australia pay for New Zealand health costs for so long. And I can see problems on the horizon with that approach. And then the third thing that patients can do is just simply not get the treatment.
Yeah. It's pretty sobering, isn't it? I didn't realize it was that straightforward to, get treatment in Australia. But yeah, that can't play out into perpetuity.
I've had several patients who've gone over there and done exactly that.
And it's not something that we should be relying on. I mean, that's a little bit, that's ridiculous. You're essentially getting another country to pay a whole bunch of money for a person that has never paid tax.
And it's not fair to the patients. They shouldn't have to uproot their lives and head off overseas, whichever country that may be to, in order to access treatment. We should be providing that here.
Yeah, especially if we have the financial means, if you look at the stats you mentioned earlier, to do so. But our model, our approach has been so siloed, and then on top of that, has been treated as a fantastic cost-saving measure, not taking into account all the other benefits.
Right, and those patients have paid taxes here. I mean, this is, they've contributed to the cost of those medicines here as a taxpayer, and would continue to do so if they were treated here.
So it really would require a huge frame shift to address this. Because I suppose if you're looking at it at a crossroads, you've got, the status quo, which is compounding over time, right? If you're constantly behind the 8 ball, and I'm sure the timeline between approval of a medicine and then funding approval is only going to get longer, because we have to wait for things to fall off patent, or we have to wait for budgets to increase if they ever would. So that's that, which is only going to get worse over time, let's just say, for argument's sake, versus an alternative, which is we have more of a Australia-style approach or a UK-style approach where we do fund these things. To stand at the crossroads and go, no, we don't want to go down route A, which is the status quo, we want to go down route B, that will require a huge amount of change in ideology or approach to this, right? It's both a budgeting issue and a valuation issue, as you mentioned.
I think it's a question of understanding for a lot of people. A lot of people aren't aware of the facts. Even a lot of the politicians aren't aware of the facts, I suspect.
Right.
That we spend 1/3 as much as other countries on medicines. Those are comparable countries with comparable income per person. Yep. So when you start looking at the facts, you start realizing, hey, well, we should change that. And when you look at the amount that we spend, it's often sold that medicines will break the bank, but they're 1% of the government's of its income. By increasing that by a smidgen, or 50% even, which would make a huge difference for patients in New Zealand, it's not going to break the bank for the government. I've drawn pie graphs where you see the change. You can't even tell the difference in the in the difference when you increase that medicines budget. Our other expenditures are pretty comparable with other countries, but the medicines is really low. So we just need to change that understanding and that mindset, and we need a 5-year plan, a 10-year plan to get us back to the middle of the OECD where we should be. And I think the government should be committing to at least a 10-year plan to do that. So there's a lot of advocacy going on. I've been fortunate enough to meet with Shane Retty and Paula Bennett, and put forward these points that we need a plan to get us back on track. And I know that a number of other groups and advocates out there are doing the same thing, and really hope that the community will start to push this forward a bit as well.
Yeah, because if no one knows about it, no one talks about it, then nothing's going to change. Right. I mean, democracy, you have to actually.
Yeah, and it's easy for the government. They want to balance the books, and if they don't have to shuffle things too much, it's easy for them. I understand that.
Yeah.
But on the other hand, people are really suffering as a result of the status quo. So things do need to change.
And it's not just the here and now or into the future in terms of treatment, but there is an implication of this into research into new treatments. You mentioned it earlier that not all drugs are even available on clinical trial in New Zealand, and it's really prescient in oncology or hematology, because if you're going to trial a new drug, typically you have to have the current standard of care.
Right.
And if we don't have access to the standard of care because it's not funded, then your patients or any patient in New Zealand would not be eligible for a trial. So that trial would never come here. So we're now not part of the vanguard pushing science in, advancing science, shall we say, for that disease.
That's totally correct. And if I just come back to multiple myeloma, which is the area that I treat, in cancer, in Canada, there were so many new treatments that were coming available on clinical trials. So there were 3 or 4 or 5 different bispecific antibodies that we had available for relapsed patients with myeloma. There were CAR T cells, and these all had come about in the last 5-6 years. And we all of us started to see that our patients stopped dying. There were all these new treatments that we could put them on clinical trials. One CAR T cell, and then one bispecific to another bispecific to another bispecific, and there were some other newer medicines there too. And so many patients were doing a lot better than they otherwise would have done as a result of access to clinical trials.
Yep.
And I still keep in contact with patients in Canada, who 5 years after going on this clinical trial or that clinical trial are in remission and basically living as a result of having been on one of these clinical trials. And none of them are available in New Zealand, and it's been very difficult to get them here. We've had one or two that we've got here. I'm trying to negotiate to get another one here to start next year. But for the most part, those clinical trials are not available in New Zealand, and the reasons are several-fold. One is we don't have access to even standard of care treatments for myeloma and other cancers in New Zealand. And many of these trials start out by treating patients who've had all of the standard of care treatments. That's their mandate to study the new drug in those patients who've failed everything else. And when patients in New Zealand haven't failed everything else because they haven't even had access to it, they're not eligible for the trial.
Yep.
And then, as the treatment progresses and becomes clear that it's an effective treatment, it often starts to move earlier into a patient's treatment history. And there it's often combined with standard of care treatments. And again, we don't have the standard of care treatments to combine with the experimental treatments. So we're missing out on those trials as well. Yeah. And then thirdly, the drug companies look at New Zealand and say, well, hey, there's a bunch of people there who aren't treated. They probably need a clinical trial. We could probably recruit really well. But then they start looking at the fact that New Zealand doesn't ever reimburse medicines until they become off patent or, for many years. And they start thinking, well, financially, it doesn't make sense for us to show that it works in the New Zealand population because they're never going to pay for it anyway. And so we're stuck in this situation where it's difficult to get companies to come and do clinical trials here, even though participating in clinical trials has huge benefits for patients and for the country. So just to talk about that for a minute, in Australia there was a study in 2015 that showed that of the 3 clinical trials networks that had done 15 clinical trials, in the years prior, they brought $2 billion worth of growth to the Australian economy, and some of that was from better patient outcomes and reduced health spending, and these trials, they bring the latest medicines for free to patients. So patients really can benefit substantially from them. Yeah. And by not even creating an environment where those trials can be accessed or enabled to run, New Zealand is really missing out.
Yeah, it's pretty scary when you think. Both these issues, medicines access and clinical trials, are intimately related, particularly in an oncology setting. And if you play that out, it's just compounding.
It compounds.
Aggressively compounds, right? Like you said.
Right.
It's pretty dismal, which is a real shame because I've obviously my day job. Going back to your argument about pharmaceutical companies not coming to New Zealand, I used to work for a big pharma company,
right? And
when I moved there, I was all so excited to bring their trials to New Zealand. And then I was talking with the leadership. They're like, "Oh no, we just don't worry about New Zealand. I know you're based in New Zealand, that's fine, but yeah, we just don't because they're not going to fund it anytime soon. And if we bring them on trial, we have to give them compassionate access. It's just not going to be worth it for us from a purely numbers cost basis to spin up a trial, compassionate access for God knows how long while they wait for it to be approved from a funding perspective." And it really kind of upset me, and that got me onto the train of like, man, what's going on here? Like New Zealand, we are part of the developed world, but we have all these weird, archaic kind of like residual aspects to us where we're slowly starting to slip behind.
Yeah, I love New Zealand. It's a great country and a lot of pluses being here, right? But there are these areas of mismanagement or where just things aren't done right. And access to medicines and promotion of clinical trials is clearly one of them. And the government needs to focus on this in a big way to just push us forward.
If you could pull a lever and make a big difference by pulling that one lever, what would that lever be?
We need more funding for medicines, and I don't care whether it comes from the health budget and they break down that silo and then they just look more carefully, where is the best balance to where should that needle sit in terms of medicines funding versus other things, so that we have the best outcomes, whether they just put more money into the medicines budget. That's really what needs to change to enable better care in New Zealand. And once we have the standard of care treatments, then all of those clinical trials will come too. And so it's a win-win situation when we do that.
Yeah, absolutely. I mean, I really do hope. I mean, obviously things aren't great right now. All the news articles are pretty dire about a lot of things. But I have a lot of hope that eventually we'll get there, because we've got a lot of really bright and engaged people. I mean, like yourself, advocating for these things. And Kiwis are uniquely very humble by nature, but it just takes a few people to actually start raising these topics and talking about it openly and honestly, and then everyone kind of comes along for the ride.
Right.
And but it has to start from people that actually see, hey, there's a problem here, and this is a potential solution, and get people on board.
Yeah, I think a lot of the docs in the system know there's a problem, and they've just been beaten down over the years, and it would be nice if they spoke up. It's great to see the patients. We see every weekend or someone in the paper speaking out about the fact that the medicines for their cancer is not being funded.
Yep.
And how long is it going to take for that to start having an impact on the government? I do think the government is taking notice. The issue with the funding of the oncology medicines at the last budget, there was a lot of pressure when they didn't fund those medicines, and in fact they reversed course and funded them. Yeah. And so I do think advocacy is playing a role in sort of lifting the bar. But the government did sort of make the claim that they had made this massive increase in Pharmac's budget, and they increased it by 10%, which sounds like a big amount. But on the other hand, inflation was 7% of that year, and we were spending something like 30% or 35% of what other countries are spending on medicine. So when you increase it by 3% and you go up to 35 or 38%, it's really, we're still well underspending on medicines, and we need to do more.
And we've got more of a population now because immigration is heading to it. Yeah. Well, I mean, this has been really interesting. If people want to find out more about your work or your advocacy, where can they go?
So I have a LinkedIn profile that covers a lot of the advocacy work. Leukemia Blood Cancer Foundation New Zealand. They have a website that covers a lot of the blood cancer advocacy. And then, send me an email if you're interested in the research.
Awesome. Well, thanks so much for your time. Really appreciate it, and all the best.
Thank you. Appreciate it.